Understanding the pathology of major depressive disorder. MDD, often simply referred to as depression, is a heterogeneous affective disorder characterized by symptoms such as low mood, loss of interest or pleasure, fatigue, suicidality and impaired sleep, cognitive dysfunction, or reduced activity lasting at least 2 weeks. Most patients with MDD will experience relapses and recurrences, and risk of recurrence increases with every successive major depressive episode. Globally, more than 300 million people suffer from MDD. MDD contributes to the nearly 800,000 deaths by suicide seen worldwide each year, and is ranked by the World Health Organization as one of the leading causes of disability worldwide. The optimal outcome for a patient with MDD is a full recovery from a depressive episode and preservation of personal and social functioning, such as holding a job and maintaining relationships. Current therapies can be effective, but for many patients their first course of treatment does not help them achieve symptomatic or functional remission. Several hypotheses have been put forward to explain the pathology of MDD, including the monoamine, glutamatergic, GABAergic, NMDA, HPA axis, and neurotrophic models. The monoamine model, for example, proposes that depression is caused by an overall functional deficit of transmitters, such as serotonin, norepinephrine, or dopamine. The monoamine model is the basis of many treatment options for MDD. However, it is now thought that the variable presentation and treatment difficulties behind MDD are likely due to dysfunction across one or more overlapping brain circuits governing different aspects of behavior. Here, we will look at 2 settings where symptoms of MDD may be impacted by monoaminergic changes in distinct circuits: anhedonia and emotional processing. Anhedonia and the reward network in MDD. Anhedonia, or loss of pleasure from previously rewarding stimuli, is a core symptom of MDD that may reflect impaired reward processing. The reward circuit includes the ventral and dorsal striatum, ventral tegmental area, and prefrontal cortex, and is rich in dopaminergic and glutamatergic connections. The nucleus accumbens of the ventral striatum receives projections from the ventral tegmental area, as well as afferents from the thalamus, prefrontal cortex, hippocampus, and amygdala. In turn, the nucleus accumbens sends projections to the ventral tegmental area and ventral pallidum. The primary output of the nucleus accumbens is then relayed through the mediodorsal nucleus of the thalamus to the cortex to modulate responses to reward-related cues. Weaker responses in these regions have been seen during a reward task in people with MDD, and resting brain activity in this circuit, primarily in the left ventral striatum, has been shown to be reduced in proportion to depression severity. Anhedonia is also seen in several neurological disorders such as schizophrenia and Parkinson's disease, each of which is linked by dopaminergic dysfunction in the reward circuit. Emotional processing and the default mode network in MDD. The default mode network of the brain becomes more active when the mind is wandering or occupied with internally directed thoughts. This network has primary nodes in the medial prefrontal cortex, posterior cingulate cortex, and angular gyrus. The subcallosal cingulate, also described as the subgenual anterior cingulate gyrus, or CG25, has been identified as a key area in emotional processing and displays high glutamatergic and serotonergic receptor densities. Stronger connectivity between the default mode network and this subgenual area have been shown to predict higher levels of recurrent, self-reflective, depressive rumination. When healthy subjects are asked to rehearse sad scripts, cerebral blood flow increases in the subcallosal cingulate, and imaging studies have shown increased subcallosal cingulate activity in patients with depression. A general feature of MDD treatments is to decrease activity in this region, with increasing serotonin function presenting as a key monoaminergic target, amongst other neurotransmitters such as glutamate that are implicated in this pathway. Treatment options in MDD. A range of antidepressive treatments are available or under investigation that target different monoaminergic and other receptor profiles such as GABA and glutamate. At this time, however, serotonergic therapies are still a primary first-line treatment option for MDD. An increase in serotonin may be sufficient to improve symptoms in a patient with a dysfunctional emotional processing subtype of MDD, but is likely to be less effective for a patient with, for example, a possible dopaminergic-based anhedonia subtype. In the future, however, evidence about circuitry biotypes could be used to help guide treatment. Patients with anhedonia, for example, may benefit from therapies that aid plasticity in striatal dopamine pathways. In the future, this more biologically targeted approach, focusing on specific symptoms, neural networks, and neurotransmitters, may be key to improving symptomatic and functional response rates in MDD.